Imagine this. Your once sharp mother begins forgetting recent conversations. Your father, a retired engineer, suddenly struggles to follow a simple recipe. The first and most terrifying thought that comes to mind is Alzheimer's, a slow, inevitable decline that seems to have begun. But what if the root cause isn't a degenerative brain disease at all, but something far more reversible, hiding in plain sight inside the medicine cabinet? This is the alarming reality for a significant number of seniors experiencing rapid cognitive decline, a little-known phenomenon called drug-induced dementia. This condition often manifests as sudden confusion, memory loss, and delirium. It is not a natural consequence of aging, but rather a direct side effect of commonly prescribed and over-the-counter medications. The frightening part is that these symptoms can easily be mistaken for permanent dementia, leading to misdiagnosis and a tragic path of unnecessary treatments, while the true treatable cause is overlooked. The encouraging news, however, is that this form of cognitive impairment is often reversible once the offending medication is identified and discontinued. In this video, we aim to pull back the curtain on this critical health issue, equipping seniors, their families, and caregivers with the knowledge needed to advocate for safer health care. Our goal is not to incite panic or encourage anyone to independently stop taking prescribed medications, a dangerously reckless action with potentially severe consequences. Instead, this is a call for informed, proactive dialogue with healthcare providers. By understanding which medications carry the highest risks and how they impact the brain, you can become a vigilant partner in protecting your most valuable asset, your mind. We'll explore 10 categories of commonly used medications, unraveling the unique ways each can hijack cognitive function. Before we continue, I've noticed that engagement has dipped a bit. If you're finding this content valuable, please take a moment to like, comment, and share it with your friends. It really helps more people discover the channel. This video is for informational purposes only and should not be taken as medical advice. Always consult a healthcare professional or registered dietitian for personalized guidance. Now, let's move on to 6 popular medications that trigger rapid dementia in seniors. To understand the most common perpetrators of drug-induced dementia, we must first journey into the microscopic spaces between brain cells, where chemical messengers called neurotransmitters facilitate every thought, memory, and command. Among the most crucial of these is acetylcholine, often dubbed the memory molecule. It is the key neurotransmitter for learning, forming new memories, maintaining focus, and regulating the rapid eye movement, sleep cycle, which is essential for memory consolidation. The class of drugs known as anticholinergics operates by blocking acetylcholine from binding to its receptors in the brain and peripheral nervous system. Imagine a lock and key. The acetylcholine is the key, the receptor is the lock, and the anticholinergic drug is a piece of gum jammed into the keyhole, preventing the mechanism from working. This blockade might be therapeutic for calming an overactive bladder or reducing muscle spasms, but in the brain, it creates a chemical drought, starving critical neural circuits of the fuel they need to fire correctly. The cognitive consequences of this acetylcholine famine are profound and can be shockingly rapid. The brain's hippocampus, a seahorse-shaped structure vital for forming new memories, is particularly rich in acetylcholine receptors. When anticholinergic drugs flood the system, the hippocampus is effectively shut down. This is why a person might clearly remember events from 50 years ago, memories already solidified in the cortex, but be utterly unable to recall what they had for breakfast an hour ago. The ability to encode new experiences is severed. Beyond memory, the fog extends to executive function. Difficulty following conversations or plotlines on television, problems with planning and organizing tasks, and a general slowing of mental processing speed. This isn't a gradual decline like traditional dementia. It can appear within days or weeks of starting a new medication or increasing a dosage, presenting as a sudden and bewildering cognitive collapse that terrifies the individual and their family. The insidious nature of anticholinergics is compounded by their pervasive presence in common medications, many of which are perceived as benign. The sleep aid, diphenhydramine, sold over the counter as Benadryl and the active ingredient in brands like Tylenol PM and Zizquil, is one of the most potent anticholinergic agents available without a prescription. Millions of seniors use it nightly, unknowingly initiating a chemical brain drain in pursuit of rest. For overactive bladder, drugs like oxybutynin, ditropan, and tolterodine, Ditrol, are frequently first-line treatments, directly trading urinary comfort for cognitive clarity. Even older tricyclic antidepressants, like amitriptyline, Elavil, still prescribed for chronic pain and migraine prevention, carry a severe anticholinergic burden. The cumulative effect is critical. The more of these drugs a person takes, the higher their anticholinergic burden, a metric directly correlated with the significantly increased risk of developing permanent dementia over time. The brain, under sustained chemical siege, may incur damage that becomes irreversible, turning a temporary state of impairment into a lasting tragedy. While anticholinergics attack the brain's specific chemical pathways, another broad class of drugs inflicts cognitive damage through a more generalized, yet equally devastating, mechanism: profound sedation. Medications like benzodiazepines, Xanax, Valium, Ativan, Klonopin, and non-benzodiazepine Z drugs, Ambien, Lunesta, are designed to depress the central nervous system. They enhance the effect of the neurotransmitter GABA, which puts the brakes on neuronal activity, inducing calm, drowsiness, and sleep. For someone struggling with acute anxiety or temporary insomnia, this can feel like a relief. However, for the aging brain, this chemical braking is not precisely targeted nor short-lived. The sedative effect doesn't magically vanish after 8 hours of sleep. It lingers, creating a persistent mental fog or a hangover that can last well into the next day and, with chronic use, become a permanent state of being. This perpetual fog manifests as a significant impairment in alertness, concentration, and psychomotor speed. Seniors on these medications may appear drowsy, disengaged, or slow to respond. They become more unsteady on their feet, dramatically increasing their risk of falls, a leading cause of catastrophic injury in the elderly. A fall resulting in a hip fracture or a traumatic brain injury can itself be a direct gateway to permanent disability and cognitive decline, creating a vicious cycle where a drug prescribed for one problem actively generates another, more serious one. The brain, languishing in a sedated state, cannot operate at its peak capacity. Forming new memories requires alertness and attention, two states that are chemically suppressed. The mind feels clouded, as if trying to think through a thick veil, leading to frustration, social withdrawal, and a misdiagnosis of depression or early dementia. The danger of benzodiazepines is particularly acute for seniors due to pronounced age-related changes in pharmacology. The body's ability to metabolize and clear these drugs slows dramatically with age. A dose that was once well tolerated in one's 40s can become toxic in one's 70s because the drug and its active metabolites linger in the bloodstream for much longer, continuously bathing the brain in sedative compounds. Furthermore, long-term use leads to tolerance, needing more for the same effect, and physical dependence, making cessation incredibly difficult without professional help due to severe withdrawal symptoms, including heightened anxiety and seizures. Perhaps the most tragic aspect is that these drugs are often prescribed indefinitely for chronic conditions, contrary to guidelines recommending they be used only for short-term, acute situations. This creates a scenario where a senior citizen may be taking a brain-dampening medication for years, their true cognitive potential forever masked by a preventable chemical haze, all while the original underlying issue of anxiety or insomnia remains unaddressed by safer, more sustainable therapies, like cognitive behavioral therapy, CBT. The perception of safety is a powerful and dangerous illusion, and nowhere is this more evident than in the world of over-the-counter medications. While prescription drugs come with mandated warnings and the overseeing eye of a physician, OTC products are purchased freely from pharmacy shelves, adorned with marketing that emphasizes relief and convenience, while downplaying significant risks. This creates a false sense of security that leads millions of seniors to self-medicate with powerful psychoactive drugs for years on end, without a single conversation with their doctor about the cumulative impact on their brain health. The belief that, if it's sold on the shelf it must be safe, is perhaps the single greatest contributor to the silent epidemic of OTC-induced cognitive decline, making these medications unseen culprits in the narrative of dementia. The most notorious offenders in this category are first-generation antihistamines and over-the-counter sleep aids. Diphenhydramine, Benadryl, and its cousin doxylamine, Unisom, are not just allergy relievers and sleep inducers. They are potent anticholinergic agents, as discussed earlier, and their easy availability makes them a go-to for millions. A senior troubled by occasional allergies or sleeplessness might start taking them nightly, viewing them as a harmless ritual. Over months and years, this daily dose steadily erodes cholinergic function in the brain, accelerating memory decline and increasing the risk of progressing to a permanent dementia diagnosis. Furthermore, many popular PM versions of pain relievers, such as Tylenol PM or Advil PM, simply combine acetaminophen or ibuprofen with a hefty dose of diphenhydramine, meaning individuals seeking pain relief are unknowingly and unnecessarily dosing their brains with a damaging chemical every time they take the pill. Beyond sleep aids, other over-the-counter categories pose a threat. Anti-nausea medications like dimenhydrinate, Dramamine, or meclizine, Antivert, also possess strong anticholinergic properties and are frequently used without medical consultation for vertigo or motion sickness. Even some antidiarrheal drugs, like those containing loperamide in high doses or the anticholinergic drug dicyclomine, can cross the blood-brain barrier and cause confusion. The critical issue is the lack of oversight. A patient might diligently report all their prescription medications to their doctor, but completely omit the handful of over-the-counter pills they take every night, believing them to be irrelevant. Consequently, when cognitive symptoms arise, the doctor is working with an incomplete picture, potentially missing the primary cause. This highlights an absolute necessity. Seniors and caregivers must treat all medications, prescribed or not, with equal seriousness, and must include every single pill, supplement, and vitamin on the comprehensive medication list they bring to every medical appointment. The most dangerous drug is too often the one the doctor doesn't know about. The relationship between cardiovascular health and brain health is inextricably linked. The brain is an exquisitely hungry organ, demanding a continuous and generous supply of oxygen and glucose delivered via a robust flow of blood. It consumes about 20% of the body's total oxygen supply, despite being only 2% of its weight. This immense metabolic demand means that any significant interruption in blood flow can have immediate and severe consequences for cognitive function. Certain medications, particularly those used to manage heart conditions and hypertension, can sometimes disrupt this delicate balance, not through a direct toxic effect on neurons, but by indirectly starving them of the vital resources they need to survive and thrive. This mechanism is distinct from the chemical blockade of anticholinergics or the blanket sedation of benzodiazepines. It is a hemodynamic crisis on a microscopic scale. The primary risk comes from drugs that can cause orthostatic hypotension, a sudden drop in blood pressure upon standing up. For a senior whose circulatory system may already be less efficient at regulating blood pressure, a medication that pushes this system too far can be disastrous. When they stand up, blood pools in the legs and abdomen, and if the blood vessels don't constrict quickly enough to compensate, blood pressure plummets. This means that for a critical few seconds or minutes, not enough blood is pumping upward to the brain. This can cause immediate lightheadedness, dizziness, and blurred vision, but the more insidious damage is cumulative. Each episode of hypotension can cause silent, mini-ischemic events. Tiny areas of the brain are deprived of oxygen, leading to cell death. Over time, this accumulation of micro-injuries manifests as vascular cognitive impairment, a form of dementia characterized by a stepwise decline in mental function. Beta blockers, a class of drug widely used for hypertension, arrhythmias, and anxiety, are a common culprit. While newer, more selective beta blockers are less problematic, older generations like propranolol can cross the blood-brain barrier and are known to cause fatigue, depression, and mental clouding. More importantly, their blood pressure-lowering effects can contribute to cerebral hypoperfusion. Other antihypertensives, like certain alpha blockers and calcium channel blockers, can also cause significant hypotension, especially during dose adjustments or when combined with other medications. The challenge for physicians is to walk a tightrope, controlling high blood pressure to prevent a stroke, a major dementia risk, without lowering it so much that it starves the brain. This requires careful, individualized titration and constant monitoring, not a set-it-and-forget-it prescription. For patients, reporting symptoms like dizziness upon standing, constant fatigue, or new cognitive issues after starting or changing a blood pressure medication is not a minor complaint. It is a crucial data point that could signal the brain is being underfed. Modern medicine often excels at treating individual ailments with specialized drugs, but this siloed approach can have a catastrophic downside: polypharmacy, the concurrent use of multiple medications by a single patient. For seniors managing several chronic conditions like hypertension, diabetes, arthritis, and depression, it is not uncommon to be taking 5, 10, or even 15 different prescription pills daily. The grave danger lies not necessarily in the number itself, but in the interactions between these drugs. The human body is a single integrated biochemical environment, and introducing multiple foreign compounds simultaneously can create unpredictable and synergistic effects, where the combined impact is far greater than the sum of their individual parts. This chemical cocktail effect is a primary driver of adverse drug reactions, with the brain often being the most vulnerable target. The concept of anticholinergic burden is the perfect example of this synergistic danger. A patient might be taking one medication with mild anticholinergic properties for allergies, another with moderate properties for bladder control, and a third with strong properties for sleep. Individually, each might be at a subclinical dose for causing noticeable cognitive effects, but when combined, their anticholinergic effects add up, creating a total burden that is high enough to plunge the brain into a significant acetylcholine drought, triggering sudden confusion and memory loss. No single prescribing doctor may be aware of the full picture, as different specialists prescribe for different conditions. The cardiologist isn't thinking about the urologist's prescription, and the primary care doctor may not have an updated list. The patient is caught in the middle, their brain paying the price for this lack of coordination. Beyond simply adding together, some drugs can potentiate each other by interfering with metabolic pathways. Many medications are broken down in the liver by a specific family of enzymes called cytochrome P450. One drug can inhibit these enzymes, causing a second drug to be metabolized much more slowly, leading to toxic levels building up in the bloodstream. For instance, a common antifungal medication might inhibit the enzyme that metabolizes a benzodiazepine, causing the sedative effects of the benzo to become exponentially stronger and longer lasting, resulting in profound delirium. This complex interplay makes the elderly, who are most likely to be on multiple medications and whose livers may have reduced metabolic capacity, exceptionally vulnerable. the solution is not to avoid necessary treatments, but to enforce rigorous medication reconciliation, a formal process where a pharmacist or primary care doctor reviews every single medication a patient is taking at every appointment to identify dangerous interactions, eliminate redundancies, and deprescribe anything that is no longer essential. The goal is to find the simplest, safest, most effective regimen possible, because in pharmacology, more is often not merrier. Perhaps the most ethically fraught and heartbreaking category of drugs linked to rapid cognitive decline in the elderly is antipsychotics. These powerful medications, such as risperidone, Risperdal, quetiapine, Seroquel, olanzapine, Zyprexa, and haloperidol, Haldol, are designed to manage severe psychiatric conditions like schizophrenia and bipolar disorder by blocking dopamine receptors in the brain. However, in geriatric care, they are frequently used off-label for a deeply troubling purpose: to chemically restrain elderly dementia patients who exhibit challenging behaviors like agitation, aggression, anxiety, and paranoia. This practice, though common, is one of modern medicine's most damning paradoxes, using drugs that carry a black box warning for increasing the risk of death in elderly dementia patients to treat the very symptoms of their dementia. The cognitive toll of these drugs is devastating. By dampening dopamine pathways, which are involved not only in reward and motivation, but also in motor control and cognition, they can induce a state of profound lethargy and apathy known as chemical sedation. Patients become zombies, stripped of their vitality and personality. They may stop speaking, engaging, or moving, a state easily mistaken for the progression of their dementia rather than a dire side effect of their treatment. Furthermore, antipsychotics can cause and worsen Parkinsonian symptoms, tremors, muscle stiffness, and a shuffling gait, further diminishing a patient's quality of life and physical autonomy. This chemical straitjacket does not address the root cause of the agitation, which is often a result of unmet needs, pain, infection, or the fear and confusion inherent to dementia. It merely masks it by rendering the patient too sedated to express their distress. The use of these drugs in this context is a last resort, yet it is often deployed as a first-line solution for understaffed and overwhelmed nursing homes because it is easier to sedate a patient than to address the complex psychosocial and environmental triggers of their behavior. Regulatory bodies have rightly cracked down on this inappropriate use, but it persists. For families, vigilance is paramount. If a loved one with dementia in a care facility suddenly shows a dramatic and rapid decline into lethargy or unresponsiveness after a new medication is started, it is critical to immediately ask if an antipsychotic has been prescribed. Families have the right to question this decision, to ask about non-pharmacological interventions tried first, and to demand a clear explanation of the risks versus benefits. No one should have their consciousness sacrificed for the sake of convenience, and this particular class of drugs represents one of the most urgent areas where informed advocacy can literally be a lifesaver. The prospect of medication-induced dementia is undoubtedly frightening, but the overarching message is one of profound hope. Unlike the progressive and currently irreversible path of Alzheimer's disease, the cognitive decline triggered by many common drugs is frequently stoppable and often reversible. The key is recognition. By understanding the unique ways different medications can disrupt the delicate workings of the brain, you are equipped to spot the warning signs early. This knowledge transforms you from a worried bystander into a powerful advocate. It enables you to ask the right questions, to provide your doctor with crucial information, and to collaborate on a safer, smarter healthcare plan. The goal is not to live in fear of medicine, but to respect its power and insist on its prudent use. Your brain is the repository of your life's experiences, your relationships, and your identity. Protecting it requires vigilance, but the reward? Preserving your clarity, autonomy, and connection to the world around you is the greatest reward of all. Let this knowledge be your shield.